Hi, everyone. On behalf of the American College of Cardiology and the Center for Systems Improvement, I'd like to welcome you to this module in the EMS and Systems of Care webinar series, Taking Clinical Quality to the Next Level. One of the usual moderators for these webinars is Tim Phelan. Unfortunately, he won't be able to join us today. So I'll be handling the moderator role. My name is Tom Bouthillet. I'm the Battalion Chief of EMS at Hilton Head Island Fire Rescue. And in that capacity, I'm very interested in continuous quality improvement and performance measures for time-sensitive emergencies. This is the sixth module of this webinar series, and we'll wrap up the major elements of the team-based quality model that we've been drilling into for the past several sessions. It's going to be an interesting event as it will outline a whole new job description in EMS, the EMS Clinical Specialist. But before we begin, I wanted to let you know that part of the webinar will include a video that appears in a pop-up window. If you experience problems seeing the video, you may need to disable pop-up blockers in your web browser. If you're watching this live, at any time, please feel free to enter any questions or comments you might have into the question box in GoToWebinar. We'll select some of them to answer on air as time permits during the Q&A portion of the webinar. If you're watching the archive recording of this webinar, please feel free to send questions and comments directly to Mic, that's M-I-C, at improvethesystem.com. The archive recording will be posted in a few days after the live session with an email notice and viewing link sent out to everyone who registered for this event. Mick will do his best to respond to questions and comments sent in by email, regardless of how long it is after the live event you might be watching this. Presenting the lecture portion of today's webinar is Mic Gunderson, President at the Center for Systems Improvement. The Center for Systems Improvement specializes in elevating the performance of community and regional systems of care for high-risk, time-sensitive conditions, as well as providing EMS system assessment and quality improvement training services. The ACC works with the Center for Systems Improvement in development of EMS and systems of care related programs and services. I'll now turn the presentation over to Mick.
Tom, I really appreciate you being here to moderate today's program. And if you weren't able to join us on our last webinar, which was held on September 3rd, just a bit of weather event was going on in Tom's neighborhood, Hurricane Dorian. And so I'm glad everybody came through it okay on Hilton Head Island, Tom.
Yes, we did. Thank you very much.
Well, we were all pulling for you. So with that, let's just get right into the video portion of today's program. And there will be a brief pause while we get that started. So just bear with us for just a moment, please. This EMS and Systems of Care webinar series is brought to you by the American College of Cardiology's National Cardiovascular Data Registry, the NCDR. And they provide the chest pain myocardial infarction registry and its new reporting tool, NCDR eReports EMS. This tool generates STEMI and NSTEMI reports for your specific EMS agency or regional system of care using the data that's already been entered by your receiving hospitals. For details, check it out at acc.org/eReportsEMS. I've really been looking forward to today's webinar because we'll be talking about a new EMS job description, the EMS Clinical Specialist. And to put today's session in context, particularly if you haven't watched the prior webinars in this series on the team-based quality model, I'll quickly recap because they've all led us up to today's topic. And if you'd like to watch any of these prior webinars in their entirety, descriptions and links are available at acc.org/eReportsEMS. Just scroll down to the resources section of that page. At the start of this webinar series, we discussed quality in EMS and healthcare at a very high level. The connection between quality improvement projects and the scientific method was explored, and we discussed how the scientific method and its associated tools can be used in improvement projects, which is something that's often referred to as improvement science. We then started talking about specifics. We talked about how healthcare provider organizations often have just one person taking on most of the responsibility for coordinating or managing clinical quality. In the hospital, they will often have a title like the cardiovascular service line manager or coordinator. In EMS, that one person frequently has a title like the EMS clinical or quality manager. And in smaller EMS organizations, that one person may have quality along with several other programmatic responsibilities. And this situation causes a bottleneck in efforts to conduct quality improvement projects. After getting all of the routine tasks done and addressing the typical stream of various clinical issues and complaints, there usually isn't enough time left to be proactive through quality improvement projects. I then described a strategy to help alleviate that bottleneck by implementing what we have been calling the team-based quality model. And for clinical matters, its mainstays are the use of clinical specialty teams supplemented by ad hoc improvement project teams. However, the model envisions someone well-trained and appropriately prepared to lead each of these clinical specialty teams, and that's the EMS Clinical Specialist, and they are the topic of today's webinar. This new EMS position is analogous in many ways to the clinical nurse specialists found in hospital settings, like a trauma clinical nurse specialist, for example. Then, this webinar series went on to describe how to apply the team-based quality model to individual organizations as well as EMS systems and regional systems of care for time-sensitive conditions like acute myocardial infarction, trauma, cardiac arrest, and stroke. We talked in detail about clinical specialty teams. We discussed how a clinical specialty team takes stewardship of a particular clinical area by monitoring its performance, staying abreast of current research and best practices, and using all of that information to make improvement project proposals to the senior management team in the form of improvement project charters. Once an improvement project charter is reviewed and approved, the improvement project is then carried out by an ad hoc improvement project team. We talked in detail about these ad hoc improvement project teams, the project charters used to define their work, and the role of the senior management team not only in review and approval of the charters, but also in establishing accountability to help teams stay on track for achievement of their project objectives. So, the leader of a clinical specialty team is envisioned to be an EMS clinical specialist. And in this webinar, we're going to explore the vision for an EMS clinical specialty program as it might exist when the team-based quality model is fully deployed and mature. It will need to look a bit different building up to that point because there won't be any incumbent or experienced EMS clinical specialists to participate in the teaching and mentoring of the new EMS clinical specialists. And many of the experiential learning opportunities will still have to be developed in these early phases of the program. So to borrow from the writings of Stephen Covey, let's begin with the end in mind as we described how an EMS clinical specialist program is envisioned to look and operate when fully deployed. We'll also talk a bit about how to get the training program elements started. An EMS organization may have several of these clinical specialty teams in one or more of the time-sensitive care areas I mentioned earlier, or even in other areas like mobile integrated health, dispatch, pediatrics, hazmat, tactical EMS, or critical care transport. Regardless of the particular area, it's envisioned that each of these specialty teams are led by an EMS clinical specialist that's received specialized training in that same area. Having a clinical specialty team led by an EMS clinical specialist is not mandatory by any means, but for the same reasons we see quality programs for clinical service lines in hospitals often led by a clinical nurse specialist, there's a similar rationale for doing so in EMS. These clinical specialists get additional training to lead these teams to their best levels of performance. We also pointed out that this same team-based quality model and its elements can be applied with a bit of modification to non-clinical processes as well, like fleet operations, supply, or IT. But in today's webinar, we're going to focus on the EMS clinical specialists. So let's first talk about what the education for an EMS clinical specialist might consist of. It's envisioned to be in 5 areas: clinical, teaching, research, quality, and general management. And in each of these 5 areas, there will be a didactic session and an experiential learning section. The didactic session will be in several formats, but it will mostly consist of directed readings from textbooks and journal articles. It can also include video and audio from formal instructional recordings, as well as selected content from websites, blogs, podcasts, and vlogs. There may be the occasional lecture or presentation, but lectures are not intended to be the mainstay like it is in most undergraduate programs. Think of this more like an apprenticeship or a medical residency or fellowship. The assigned didactic learnings can come from a very wide variety and number of sources. So that means we'll have to carefully curate the content we want to select to best align with the educational objectives. It's not so much of read all of this book and all of that book, and all of that one too. It's going to be more specific. Read this chapter and these pages from this text, and these specific articles from these specific journals, and those specific websites, blogs, podcasts, and vlogs. This will be the case for the directed reading assignments in all of the areas: clinical, teaching, research, quality, and general management. In the clinical experiential learning, it's not so much about having the EMS Clinical Specialist trained to perform more advanced procedures, although that could be an option for some programs. I do anticipate that they will get more in-depth training on the things already in their armamentarium to get them to a higher level of knowledge, skill, and judgment. But frankly, the clinical rotations are really more about having a deeper understanding of how the rest of the processes in the continuum of care operate in their specialty area, so that they can help influence the design and operation of the EMS elements of care in ways that better support what happens downstream when the patient arrives at the hospital and later transitions to post-acute care and secondary prevention. Especially as EMS starts to deliver a broader array of services through mobile integrated health programs, there may be lots of new ways EMS can support post-acute care efforts, all in addition to the more traditional EMS role in preparation and support of the emergency care provided in the hospital. We want to provide the EMS Clinical Specialist students with extended exposure to these settings and processes, and to help them establish working relationships with hospital process managers and clinicians. This will allow the EMS Clinical Specialists to use their new insights and contacts to guide initiatives that not only make EMS processes work better, but also enhance the efforts, again, of the downstream emergency and post-acute care teams. The experiential learning for research should ideally precede the experiential learning for quality. This is because it would be very useful to have students come into their quality training with a solid grasp of the scientific method and the processes and disciplines of research, so they can apply it to improvement projects with clear population definitions, hypothesis statements, good design of experiments, control of extraneous variables, hypothesis testing, and data visualizations, hence the use of the term improvement science. The ideal places for doing experiential learning for research would be in places that routinely use research methods in their daily activities. It does not have to be at a medical research facility, although that would be a plus. It might be at a company that has research and development teams that routinely conduct experiments to refine its products and processes. We want the student there to observe how researchers and research teams conceive, design, and conduct experimental quantitative research. And it would be great if they could also get rotations to get some exposure to qualitative research. And that could be with social scientists or even business market research firms. Academic centers may be a place where such opportunities can be found, but don't neglect looking for experiential rotation opportunities with local businesses. The experiential learning for quality might also be with businesses. Look for places that have mature and effective quality programs, particularly in manufacturing, as they tend to be more sophisticated in their use of the industrial qualities that, frankly, many healthcare organizations are still struggling to implement. Some rotations with hospital quality departments would also be entirely appropriate, but I would suggest getting exposure in a non-healthcare business setting first. Service industries that have robust quality programs are also a good choice. We want to expose students to organizational cultures that have deeply embedded quality management practices in their everyday operations. Many communities have local chapters of the American Society for Quality. Attending those meetings and even joining the organization can be a great way to see how others manage quality, and it may be a good place to find good opportunities for experiential rotations with top quality practitioners. The experiential learning for teaching is primarily about adult education design, delivery, and assessment. One of the bigger tools in the improvement toolbox is workforce education. It can be used to address both quality assurance issues as well as quality improvement interventions. But to do that effectively, you need to have clear educational objectives, sound instructional design to meet those objectives, and ways to assess if the education was effective. On the rotation, we want to expose the student to places where that happens on a routine basis. It might be at an academic setting when a new course is being designed or undergoing a major revision. It might be at a large company with a corporate training department that is constantly developing new classes for its employees. Of course, if your organization has a strong EMS education department that develops original content, that would be a place to spend some time, but exposure outside of EMS and healthcare is strongly recommended, primarily to get fresh perspectives. The experiential learning for management has lots of possibilities. There can be leadership elements as well as operational elements. Rotations inside and outside of EMS and healthcare are also good to have here. This rotation is about learning how different people in different organizations and settings lead and manage. It can include something about the particular business and processes where the rotation is taking place too. You can find great leaders and managers to have your students spend time with in all kinds of different companies in all kinds of different functions. How do the managers of the clinical areas of hospitals lead and inspire their teams? How do they manage their responsibilities, set goals, motivate staff, deal with problems and complaints, manage their time and calendars, address competing priorities, and manage their budgets? We can also set up EMS Clinical Specialist student rotations with the senior leaders of their own EMS organizations and some other EMS organizations. Getting a broad perspective on management structures, philosophies, and methods is an important objective here. If the student has spent most of their career in one type of EMS organization, having a rotation with their own organization as well as other types of organizations would be great. Mix it up: fire, third service, private, hospital-based, paid and volunteer, urban and rural. Rotations at different levels is also desirable. Spend some time with an operations manager, field supervisor, HR manager, billing manager, equipment and supplies managers, comm center managers, and the fleet manager. The student should spend some time seeing how these managers do what they do, build some relationships, as well as learn something about these other functions. The bigger objective here is exposure to different managers in different settings at different levels to get insights on how they manage. Learning something about the different processes these managers oversee is icing on the cake. Rotations outside of healthcare might also include local businesses as well as local government. Again, consider a local manufacturing and service firm. Consider the local public health department. EMS has a lot of public health in its DNA. We all should probably spend more time learning about the tools and techniques of population health. With local government, consider the city or county manager, police chief, or sheriff. I can also see a scenario in which there are some remote rotations, perhaps as options, in any of the areas. Imagine having a chance to do a rotation at a resuscitation research center if you're an EMS resuscitation specialist. How about a management rotation at FedEx or Amazon or Ritz-Carlton, or one of the other more recent winners of a top award from the state or national Baldrige program for performance excellence, to learn how their culture and processes operate in a way that helps them thrive. For all of these rotations, there should be some specific experiential learning objectives. It may be fun just to hang out with the managers in these various organizations and settings, but this is not about industrial tourism. The value of the rotations may be well served if guided by a checklist of things that the student and manager should talk about and try to experience. That will also help the manager be better prepared for the student's time with them. The operation of the EMS Clinical Specialist training program is something that also deserves some careful consideration. By taking more of a postgraduate approach to this kind of education, we can actually utilize the EMS Clinical Specialist students to develop program content. The program design will need to start with some educational objectives, a schedule for what, where, and when didactic topics and rotations occur, and in the very first iterations of the program, the faculty, members, and advisors to the program can begin to write these up, but I would suggest that the students themselves participate in developing the objectives, the agendas, and the timeline. This should be used as one of their experiential learning opportunities. So let's consider an example, establishing an acute coronary syndromes or ACS clinical specialty team. We would begin by deciding what we want the EMS ACS specialist to be able to do and what knowledge we think they need to have to do their job well in leading an ACS clinical specialty team. We can divide that up into two parts, the things specific to ACS and the things that all EMS clinical specialists will need to do and know in adult education, management, research, and quality. Let's start with the things specific to ACS. One of the things that I think an EMS ACS specialist should have a pretty strong command of is the recognition of ACS and the differential diagnosis between the various conditions that are within the ACS category, including STEMI, NSTEMI, and unstable angina. That said, this general idea would be shaped into specific educational objectives. With the educational objectives established, we would start to curate, carefully select what books, chapters, sections of chapters, blog and vlog posts, instructional videos, etc. that we might want to include in the directed learning assignments to meet our educational objectives regarding the recognition and diagnosis of ACS. We would also try to figure out experiential learning opportunities to reinforce and practice what was in the didactic section. These will commonly be rotations in specific clinical settings with specific clinical learning objectives. In most cases, we would want the student to have successfully completed their didactic objectives before doing their experiential learning rotations. The EMS or cardiovascular specialist student would need to have some understanding, for example, of biomarkers and the emerging role of high-sensitivity troponin testing before they go into a rotation to see and discuss how biomarkers are utilized and interpreted with an EMS physician or cardiologist. For the things we want the EMS clinical specialist to learn outside of the clinical area, we can take a similar approach. In the quality area, I think that any EMS clinical specialist should have a pretty good handle on how to take raw data of a particular type and be able to build the appropriate type of statistical process control chart with appropriate statistical software tools or Excel plugins. Again, we would need to curate the didactic content to meet that objective and then try to find a place where they can do a rotation with someone somewhere that has mastery in use and application of information from statistical process control charts so that the student can practice and be coached in that skill. For this one, the rotation may be at a manufacturing facility that uses statistical process control as an integral part of their daily processes. I would personally love to get a group of knowledge-hungry EMS ACS specialist students into a room with some enthusiastic cardiologists, EMS physicians, and cardiovascular clinical nurse specialists to have a heady discussion about the knowledge and skills objectives for an EMS ACS specialist program. That august group would also be wonderful to make suggestions for the didactic assignments and experiential learning rotations. Imagine similar discussions with educators, quality experts, researchers, and managers to help craft things in each of those areas as well. That's exactly how all of this is envisioned to unfold. In those meetings, the EMS clinical specialist students themselves would be responsible for taking notes and turning the content from those discussions into documents with Mager style of educational objectives and listings of the didactic resources to be used and the rotations to be spelled out. They will need some coaching to do this, but it is doable with proper preparation for that meeting, like having them learn what Mager-style educational objectives are and getting some practice on how to write them leading up to that meeting. So going through that or similar processes is what's going to be needed to get most of the curriculum built. Some of that will be specific to each clinical specialty, but most of it will be shared between specialties for the management, teaching, quality, and research areas. The final element of the EMS Clinical Specialist program design is the Capstone Project. This is where the student synthesizes what they have learned to conduct a research or improvement project independently or as the leader of a project team. That project should be of a magnitude appropriate for submission to a medical science conference for presentation as a poster or oral presentation. It should also be written up as a full paper appropriate for publication in a peer-reviewed journal. But some of you out there might be saying, wait a minute, being a student in an EMS Clinical Specialist program is going to be a lot of work. Why would I or anyone else want to go through all of this? What's in it for the student, especially since it does not count towards an academic degree, or not yet anyway? There may be several factors that could motivate EMS professionals to participate in a program like this. But clearly, this is not for everyone. We want students that are very intrinsically motivated, that want to be at the peak of their craft, that are willing to put in the time and effort, that want to play a larger role in service to patients, the community, the system, and their employing organizations. That said, many people in EMS want to advance professionally, but want to stay on the clinical side rather than the managerial side. While there may be a couple positions where this is possible, there's usually only a couple of them, even in larger organizations, and so the turnover is usually very low. In my view, this has contributed to the failure of EMS to keep many of the best and brightest clinicians that have passed through our ranks. An EMS clinical career ladder can help change that. We should provide more ways for our colleagues to grow professionally and stay on the clinical side if they so choose, and hopefully receive higher levels of compensation. If you're a field clinician, your clinically oriented career path can move forward with temporary participation on some ad hoc project teams. Get a taste of improvement science and working at a systems level on projects that impact the whole organization. Do well at that level, and you may get the opportunity to be appointed to a clinical specialty team. Do really well there, and see if you can get accepted into an EMS Clinical Specialist training program. Along the way, senior management should see the value that you and the other participants bring and recognize these steps on a clinical career ladder as professional advancements with additional status and pay. As these programs first get started, that may not happen right away. The program and the individuals in these programs need to demonstrate their value. But at the end of the day, getting appointed onto a clinical specialty team and successfully completing an EMS Clinical Specialist program should be considered major professional advancements on par with advancements on the administrative side. It should also be possible to continue working in the field to some extent while serving in these roles, even as an EMS Clinical Specialist. As the program matures, I think it would be entirely appropriate for those wanting to take full-time clinical management positions as the EMS Training Director or EMS Quality Director to be required or expected to have stepped up through the ranks of the ad hoc project teams, clinical specialty teams, and serving as an EMS Clinical Specialist. After all, in so doing, they will have received higher levels of clinical training complemented by training and experience in management, quality, research, and adult education. There's another motivation too. As people grow professionally in EMS, many want to have a seat at the table where clinical policies, procedures, protocols, and equipment decisions are all made. Many people want to make a difference, and often a bigger difference than just working on a frontline unit. This is not to diminish the importance of the front line, but there's an opportunity when working at a policy level to impact the entire community, not just the patients you care for. The various levels of team-based quality model participation provides these sorts of opportunities in a more structured way. As this gets started, there's also the motivation of wanting to participate in something new. Being in the first group to do something, being a pioneer, has a strong appeal for many. There may be another motivation as well. The project teams, clinical specialty teams, and EMS clinical specialists are going to be doing things that are hopefully going to generate publications and presentations, lots of them. Every EMS clinical specialist will do a capstone project. That project should lead to an abstract that gets presented as a poster or as an oral presentation. Every one of those should be submitted for publication as a full paper. Every well-conceived and executed improvement or research project undertaken by the ad hoc project teams should also generate abstracts and full papers. The longitudinal tracking of progress over time by the clinical specialty teams can also lead to publications and presentations. This will bring a lot of attention to these programs. Coming from an EMS provider organization or system with these programs in place and having your name included as one of the authors on some of the oral abstracts, poster presentations, full academic papers, trade journal articles, these will all have significant value when applying for promotions locally or applying for jobs with other EMS organizations, even if the EMS Clinical Specialist program does not confer a degree. I hope this all gets connected to a degree program at some point, but this is something that an EMS organization or EMS system can actually start doing now. But some of you out there who are already senior EMS managers or medical directors may be saying, wait a minute, putting an EMS Clinical Specialist training program in place is also going to be a lot of work for our individual EMS provider organization or for our system. Why would our organization or system want to take this on? Locally, EMS provider organizations and EMS systems operate in very political environments. Political savvy senior managers know that they need to generate positive political capital. Political capital is the sum of all the goodwill, trust, and influence that can be earned and accumulated with the public officials, media, the business community, academic community, medical community, your own employees, and other stakeholders. Political capital is gained through positive accomplishments, projecting a positive public image, and having positive interactions with patients and bystanders and your own staff in the course of daily operations. There can be a loss of political capital when those same sorts of things are negative. Political capital is spent when there's something that's needed from others that doesn't necessarily offer direct benefit to those being asked to provide that something. For example, there's not a benefit to a city manager or elected official when you request a budget increase, salary increases, or other resources. But when the request is made by an agency with lots of political capital, meaning that they have strong support from the public and the media and the workforce, the elected and senior appointed officials are much more likely to approve such requests. Political capital alone does not drive the decision, but it can certainly have a very strong influence. If you don't have much political capital built up, the likelihood of approval goes down dramatically. Similarly, if something bad happens, the political capital that your agency or system has built over time can make it much more likely that people will give your agency or system the benefit of the doubt and move on, feeling that you do great work overall and that the negative event was an outlier. The team-based quality model with its EMS Clinical Specialist component has the potential to generate a lot of positive political capital, and it can generate positive political capital on several levels. First, it's new, it's innovative. Being an early adopter of anything of value has a very positive cachet, contributing to your political capital. As mentioned a moment ago, this whole model, when managed properly, is set up in a way that can generate a lot of work worthy of being shared across the healthcare professional community through presentations and publications. Conducting good improvement and research projects should not be the exclusive purview of a few academically oriented EMS medical directors and university researchers. Incorporating improvement science and research into clinical and non-clinical process management should simply become the way you do things in your organization or system. This helps institutionalize the conduct of improvement and research projects at a level of quality that qualifies for scholarly publication in peer-reviewed medical journals and presentations at national medical science conferences and articles in national trade journals and conferences. All of these things generate a lot of positive political capital for your provider organization and system. These are also the sorts of things that build a very positive reputation for your provider organization or EMS system in the eyes of the EMS community, which helps attract the best and brightest to want to work with you and participate on these teams, and perhaps aspire to go through the EMS Clinical Specialist training. Even more importantly, it can help retain the best and brightest you already have. Too often the best and brightest that come into EMS, particularly when they're really passionate about the clinical side of things, leave. They often leave for lack of professional growth and promotional opportunities on the clinical side. They often have to go elsewhere for that because we have not created organizational structures that help them grow, help them contribute, help them get a seat at the clinical policy table, and provide them with better clinical promotional opportunities. Some will still leave, but even when they do, they should not be leaving EMS because we failed to challenge and engage them clinically and intellectually. And there's more reasons for your organization or system to do this. Far too often, we promote people into EMS preceptor positions, supervisor positions, quality manager positions, and even higher levels of responsibility without appropriate training to prepare them for these positions, and little in the way of formal training and coaching after they're in these positions. In general, our succession planning in EMS is woefully lacking. Beyond the clinical part of the training provided to the EMS clinical specialists, and to a lesser degree to the clinical specialty team members, there is the adult education, quality research, and management training they will receive as part of the regular meetings and utilize as part of their projects. Having programs like these in place can build some foundational knowledge and experience in these areas for a big chunk of the workforce. It starts to build some bench strength. It provides an opportunity for people to step up and demonstrate their drive and talent, so when the senior management team has a promotional decision to make, and when it considers its succession planning, there are people that have shown the right stuff and can be encouraged and supported for advancement on the clinical and managerial side. There may be something to be said for the idea of having your incumbent clinical and quality managers be the first ones in the program. Maybe other members of the management team should go through the non-clinical portions of the EMS specialist training, with just the management, adult education, quality, and research sections. There is value here for the training and development of your future and current management team. How about another reason to do this? One of the things about quality management that's a bit counterintuitive for some people is that when it's done well, it decreases costs. Operating with higher quality does not have to come with a higher operational cost. A well-designed process that operates with high compliance will yield better outcomes with more efficiency. Those efficiencies translate into lower costs. You also need to design in ways at a systems level to ensure that EMS participates in the economic benefit it brings. We have heard over and over again how time is muscle, and time is brain, and time is tissue in AMI, stroke, and trauma. So with well-designed processes, we can decrease time to treatment, which saves cardiac muscle cells, which saves neurons, which saves tissue. This contributes to less severity, which saves money. EMS needs to participate in those shared savings programs. But to do so, we need to have strong data that demonstrates measurable EMS contributions to those savings. The team-based quality model, with clinical specialty teams tracking performance using solid data, with ad hoc improvement projects making incremental and breakthrough improvements, and having their impact magnified through sound leadership and coaching from EMS clinical specialists, can help make that happen. And the most important reason to establish these programs is that they bring a whole new slew of people to bear on improving clinical processes and innovating and making things work effectively and efficiently. That's directly supporting the core mission for why our EMS provider organizations and EMS systems of care exist in the first place, to improve the health and safety of the patients and communities we serve. Obviously, it will be a lot of work to start instituting the team-based quality model and then put an EMS clinical specialist program into place. But there may be a way to have many hands make light work. Indulge me for a moment and envision a scenario in which we have several EMS systems where the team-based quality model has been implemented. Each community has several active and productive clinical specialty teams, ad hoc project teams, and are now ready to bring their best and brightest into EMS Clinical Specialist programs. It would make sense to have these EMS systems work together. Instead of having an EMS Clinical Specialist program with just 1 or 2 students each, perhaps the systems work together. Perhaps between several EMS systems, we have 7 EMS ACS specialist students ready to begin. Perhaps they meet and collaborate with each other online. They may have separate experiential rotations, but they could do much of the ACS didactic work together. I'm using arbitrary numbers here, but the same could happen with a half dozen EMS stroke specialists, 8 EMS trauma specialists, and 7 EMS resuscitation specialists coming from a few different EMS organizations. And all 28 could do the didactics together on the non-clinical sections. I really hope that happens, and I hope the communities will be willing to share their EMS clinical specialist objectives, curated didactic content lists, and experiential rotation information with each other. With a little bit of coordination between communities, we could even divvy up the work so that each community does a piece or two and then all the pieces are brought together to form the whole. The communities can continue to work together to refine the curriculum over program iterations. And in case you haven't connected the dots yet, the same sort of cross-system collaboration can be done between clinical specialty teams, and that creates wonderful opportunities to have multi-system ad hoc improvement projects and multi-system EMS research projects. These are the kind of implementation scenarios we're trying to work towards. A couple places have already signed up, so to speak, and a few more are in the queue. I think it's going to be quite an adventure. If your EMS system is interested in being a part of this, let me know. If you decide to take this information and build a program on your own, that's great too. The important thing is to step up and try it. I'd suggest starting with the clinical specialty teams and the ad hoc improvement project teams. See who your shining stars are from those efforts, and when the timing is right, encourage them to jump into an EMS clinical specialist training program. Also consider enrolling some of your incumbent managers and supervisors, but please go for it. So that's the vision for the EMS Clinical Specialist program and its connections to the rest of the team-based quality model. So what do you think? Have any questions? Let's go back to the live session.
Okay, so while we give a little time for the live audience to type in some questions, I'd like to start things off. Mick, that was really interesting, and I was struck by in particular, with your comments about generating positive political capital, because we've definitely seen that on Hilton Head with our cardiac arrest program, and how that's given us a louder voice for things that we'd like to do in the community, and it's given us more credibility when we go before the town council. So when we start thinking about like an EMS clinical specialist, I think it's worth noting that a lot of times EMS systems have pain points with hospitals. It could be something like emergency department diversion, or it could be something like an increase in interfacility transports. And you want that goodwill, you want that political capital because, for example, you might be wanting to establish a health data exchange. So you want good relationship with the hospitals. But at the same time, when we start really giving broader education to these EMS clinical specialists, and we're digging a little bit deeper at our quarterly STEMI meetings and things like that, we might have a cardiac arrest patient with ROSC who didn't receive targeted temperature management, even though they weren't obeying commands, or we might find an isolated posterior STEMI that wasn't cathed until the next day and had a diagnosis of non-ST elevation myocardial infarction and had a missed opportunity for reperfusion. These can be really sensitive topics for hospitals. And so STEMI care 10 years ago, you knew you were high functioning if you were transmitting ECGs and if you received feedback from the hospital. It seems to me that STEMI care in 2019 and beyond, feedback needs to be both directions. Feedback from the hospital to EMS, maybe sometimes feedback from EMS to the hospitals. Can you talk about that as far as this role as the EMS clinical specialist and give any advice that you might have about broaching some of these difficult topics where sometimes it might make the hospital feel defensive, but we're all trying to be on the same page and improve quality.
No, very valid point, Tom. And I really want to emphasize that this should really be a bi-directional sort of process where when we start using the clinical specialty teams to aggregate the data across hospitals, across EMS agencies, and even just between one hospital and one EMS agency, the picture comes into much sharper focus. And so what I envision as this all begins to unfold is we'll have more metrics by which to evaluate the EMS care, the emergency department care, the cardiac cath lab team care, and even post-acute care with referrals into cardiac rehab and secondary prevention and those sorts of things. But we'll also have measures at a systems level. And I think the primary emphasis should be on the system level to see whether or not our system of care, whether it's cardiac arrest, trauma, stroke, what have you, is working well. And when we find issues there, then we can start to drill down and see, well, where were there some chinks in the armor? Was it that we chronically tend to have a significant false positive rate with EMS declaration of STEMI alerts, or maybe EMS is declaring the alert in the field, but the emergency department, for whatever reason, isn't pulling the trigger and actually activating the cath lab team based on the input from the field. So we can begin to kind of parse out exactly where the process issues are and work together as a team to get through those issues. And I think if that's bi-directional, where the hospital identifies maybe some issues with the way it's calling STEMI alerts, and EMS is bringing up issues with how quickly they're responding to the STEMI alerts and those sorts of things, I think that will begin to gel things together as a team. The other point is when they go on these experiential rotations, part of the objective is for them to develop some better professional relationships with those process owners in the hospitals, with the trauma surgeons, with the stroke interventionalists, and the cardiac interventionalists, etc., as well as the rest of the nursing staff and other people involved in that care team, so that when they have those conversations, there is some personal relationship there rather than just being, showing up once a month or once a quarter and reviewing cases. So that's what I'm hoping will help us get through kind of those social interaction issues that could potentially, as you point out, gum up the works.
So John Riggs here has a question. He asks, is there a program like this already operating, someplace that has a model curriculum and objectives developed? There are a few EMS-specific graduate programs already. They probably aren't interested in developing a whole new degree or certificate program.
Yeah, so we see some EMS clinical specialty work already out in the industry. We have critical care transport. Number of departments have hazmat specialists. So there's a number of things along those lines that are already in place that could be the starting points to formalize those sorts of programs and expand them into a wider range of activities. And some EMS systems have EMS clinical supervisors that have received some additional training, but it usually isn't in a particular area. And so that may be where this is a little bit different than some of those incumbent programs. But something just as we've described with a EMS cardiac specialist or trauma specialist, etc., I'm not aware of any incumbent programs at this point anyway. I'd be eager to hear about them if anybody listening to this webcast can, kind of let us know. Love to hear about it.
Shawn Christopher left a very nice comment. He says, sorry, no questions, just a comment. While they've all been great talks, this is by far the most motivational. It was a pleasure listening. Thanks, Mick.
Well, thank you. It's all been kind of building up to this, as I mentioned at the start. So glad you're enjoying it. And hopefully, we're going to have some folks in the audience actually start working towards trying to implement this. And as I pointed out at the end of the video, I would appreciate getting a heads up about it so that hopefully we can provide some connections between these different programs around the country that might start popping up or at least showing interest, and try to support them.
So Mick, that raises a good point. And I think on previous webinars, Tim, I know if he was here, he usually has a comment. He really wants to kind of narrow it down, make it simple. How do you start? And so would you think maybe just one clinical specialty team, let's say pediatric care, and then have one pediatric care coordinator who could then become the EMS clinical specialist in pediatrics, and maybe that individual attends a hand-heavy instructor course or visits a pediatric emergency department, or you start plugging that individual into best practices in emergency pediatric care. Is that on the right track or off base, or what do you think?
Yeah, I would start with the one clinical specialty team, absolutely. And with that clinical specialty team, have the ad hoc improvement project teams. And just to kind of reiterate the point or the difference between the two, the clinical specialty team is a standing committee. It will exist over time and takes long-term stewardship of that particular aspect of care. And then as they identify improvement or research project opportunities, then they write up a project charter that goes to senior management. They approve it, allocate resources, and you have your ad hoc team that executes on that particular project and then disbands. And through the course of having that team in place and the various ad hoc project teams in place, I think you'll begin to see who the most promising candidates are for the clinical specialty teams. I wouldn't pick the person right out of the gates. I would closely evaluate what the performance and participation is from the people in those early stages. And on the basis of that demonstration of interest, capability, and merit, so to speak, then identify who to maybe push forward into EMS clinical specialist training. The other part I'd like to suggest as a starting point is consider the activities that your agency is already planning to do, even before you even heard of this. Like Tom, I know in your department you're looking at implementing video laryngoscopy. So you're going to go ahead and do that project anyway, but if you did it in the format of an ad hoc improvement project team, again, that starts letting everybody get used to the format, writing up the project charter, having the senior management team opine and provide some feedback, and then monitor the activity of that project team with the milestones that were established in the project charter at the start. And I think with that approach, you can begin to incrementally work towards this without really overloading the system, so to speak, with trying to do too much at once. After all, you do eat an elephant one bite at a time, right?
You do, and I think it's really important, maybe your first foray into a clinical specialty team, you don't want it to crash and burn. I think it would be harder the second time you tried to do it. So I definitely agree with taking something that has maybe not low risk of failure, but something you're going to be doing anyway that there's already some excitement about. And I think video laryngoscopy is a good example because we introduced the salad technique for airway decontamination. We taught it to the EMTs and the paramedics. Everyone seems to like it a lot. And starting next year in South Carolina, it can be on a mannequin. It doesn't have to be on a live patient, but any paramedic that's authorized to intubate is going to have to show that they have 8 advanced airway encounters a year. And so, for example, one way to document that would be to upload a video file of each paramedic doing that. Could be on a mannequin, what have you, and then uploading it to a shared drive or something like that. So you actually are collecting the video clips to prove that you're doing the mandated quality improvement. And maybe if a clinical specialty team is coming up with that kind of stuff, we're going to have more buy-in. We're going to have better compliance with it, and they're going to have ideas that maybe I wouldn't have thought of. So that's great advice. I'll probably take you up on that.
Well, and the other thing I'd like to suggest as a starting point as well is maybe you do this at a more of a systems or regional level. A lot of communities have like a a county or a regional EMS regulatory agency or medical control authority, that also might be a place to start this. So rather than having one agency doing it on their own, maybe a group of agencies that work together as a region might try to implement these same sorts of structures. And again, it gives you maybe a little bit larger pool of people to draw upon for the teams, larger ends for your data collection, and just more resources to potentially work with to, again, make the load a little bit lighter for everybody and share the work a little bit. And to the extent that we can magnify that between multiple agencies or multiple regional systems across the country, I think will make it even the more easier.
So one last question. This is from Thomas Jarrett. It says, Mick, how would this program differ from Wake County EMS and their advanced practice paramedic program?
Yeah, so I mentioned earlier that a number of agencies around the country have EMS clinical supervisors and these sorts of things. So I would kind of put it in that same category. And where this differs a bit is that the EMS Clinical Specialist program is within a particular clinical area rather than on a generalized basis. And my understanding about the program in Wake and other ones like it I'm aware of in other parts of the country is that these are generalists, not specialists. So they have received advanced training not just in one particular area, but across the entire scope of EMS practice. And so that I would see as perhaps the primary differentiator here. The other point is that the training typically provided with those organizations, as I understand it, and I could be off base here, doesn't go a lot into the other related issues of adult education, general management, quality management, and research methodology. Again, I could be wrong there, but that perhaps is another point of differentiation between some of those incumbent programs.
Well, I'll tell you what, Mick, I like Wake County EMS so well. As you probably know, Ted and I filmed a web series there, and so we did look at their advanced practice paramedic system, but I'm willing to go back if you are. We could spend a weekend there with them and find all about it, and maybe they'd be interested in what you're doing with the Center for Systems Improvement.
Yeah, well, maybe we can get Dr. Gabanis and some of the other folks on board with this. I'd love to have a road trip.
Unfortunately, we are out of time. For more information about the new eReports EMS reporting service in the works at the American College of Cardiology, please visit acc.org/eReports EMS for more information and to access the links to view prior webinars from this series.
So on behalf of the American College of Cardiology and the Center for Systems Improvement, I want to thank everybody so much for attending today's webinar. We'll send out a link to the recorded version of this webinar soon, so please share it with the folks you would like to know about the EMS Clinical Specialist program and the team-based quality model. And so that'll wrap it up for today's presentation. Thank you.